Hi there, I'm Jill Consort Beck, and I am the host of Going the Distance with Go Long. I am so excited to be here because I am with Amanda Olson. She is a pelvic floor therapist, but also owns this company, Intimate Rose, which is tangential to her practice. And I am really excited to get into understanding how people would engage with a pelvic floor therapist, and what's involved in that and why it matters. This isn't a luxury. This is something that is very much a part of women's health, and we're going to get into it. So I'm excited. So Amanda, welcome to the show.
Thank you for having me, Jill.
All right. So how did you get here? Because pelvic floor therapist wasn't something I really heard of, I would say, until a friend of mine, she had a baby probably like 2000, like 18, 19, and she started talking about her pelvic floor and how she couldn't lift weights anymore. And that was literally the first time I had heard of this occupation. So talk about how you got here.
Absolutely. Well, there's how I got here and there's how my profession got here. And interestingly, what you just described is a pretty gold standard case of how a person first encounters pelvic health physical therapy. As a profession, pelvic health physical therapy has been around formally for 42 years as a formal body part of the American Physical Therapist Association. We have been credentialed to do this for a very long time. I've been doing it for 15 years. Most patients and most people are very curious as to what would make a person decide to do intravaginal and intrarectal exams for a living. And that's a very normal question to ask. I finished my doctorate degree in physical therapy, specifically specializing in pediatric neurology. And within the first year of being a brand new professional, I had a very bad accident. I was very young, and I'm not a thrill seeker. I'm a runner. I'm slow and steady as she goes. I like my feet on the ground. But I found myself out camping in nature, and it was one of these scenarios here in Oregon where I live. It's very beautiful, and a bunch of people were cliff jumping, and they were jumping into a very deep part of the river where it's very still, apparently deemed safe. But the memo that I did not get is that when you jump off a cliff into water, you're supposed to land straight. And I landed in an L bottom first. And at 40 feet, water behaves very much like concrete, and I annihilated myself. I was very significantly injured. I critically injured my low back and my pelvis, and I had to be pulled out of the water. And I'm very lucky because if I'd rotated a little bit more or landed a bit more awkwardly and hit my head, I'd be gone. But the luxury that I did get is that my physician recommended me to a pelvic health physical therapist to help put me back together. Pelvic health physical therapists treat all the people, all genders, all backgrounds, all ages for a wide variety of different issues, which I'm sure we'll go over. But I was there for pelvic pain. And my pelvic therapist and I worked together for about 6 months, and she helped put me back together. And I went on to have 2 babies and run marathons, and I'm fine for all intents and purposes. But it changed my life. And at the end of my treatment, she said, Amanda, you need to quit pediatrics. You need to go and recertify. You need to be a pelvic health therapist because there's not enough of us and you have the right personality. And at the time, this was 16 years ago, there was a couple hundred in the country, and now we are thousands. We are in every state. We are global in physio land, and this is my purpose. This is what I do now.
Wow. Yeah, a lot of times it takes, something life-changing, a lot of times with your health, to really, make that dramatic shift, whether it's the health of yourself or the health of a loved one, where you're just motivated to do that. And obviously, it's fantastic that you were able to find one of these very rare professionals at that point in time, that your doctor was actually in a position where they knew about this. Because I'm wondering how many doctors back then really knew about this. And I mean, you even see this with like menopause care in terms of doctors not knowing what to do. And honestly, medical professionals in general are so stressed out. And you're lucky if you get more than 15 minutes with your GP when you meet with them once a year. So thank goodness you had a really in tune doctor to help set you on that path, because it made all the difference between, we'll argue, a full recovery versus something that could have really negatively impacted the rest of your life. So one of the things that I was thinking about going into this, and you kind of touched upon it, is that you said that you pelvic floor therapists attack and help, I should say, all genders. So I was wondering, because you only hear about it really with women, but you also work with men and other types of genders?
Yes. Yep, we treat all the people and a wide variety of age groups. There's a lot of different issues that can come about that would warrant a man or a child. A lot of people think about women being pregnant and having babies or having pain or different gynecological disease processes that warrant pelvic health therapy because of pain or incontinence or bowel issues. We treat bladder, bowel, gynecology, abdominal issues, and pain. And so for men, we treat them after prostate cancer. They experience incontinence and pelvic pain as well, and some sexual dysfunction. Men have pelvic pain too. They slip and fall just like everybody else. A fall on some ice onto that tailbone can drive a world of hurt. They can also have chronic clenching patterns because of stress. People of all different genders respond to stress different ways. And you think about people that get headaches or TMJ issues from grinding and clenching. There's an equal population of those people. There's like 80% overlap that are also clenching in their pelvic floor, and that can drive a lot of pain. They experience issues with sitting or having bowel movements. They experience issues with intimacy. So we treat them as well. And then on the pediatric side, we treat kiddos for bedwetting and bladder issues, constipation. We treat them for different genetic conditions that have consequences in bowel and bladder function as well.
Got it. What would make someone decide, like, okay, I hurt my lower back, I have some pain? What would make someone maybe think about going, if there's a fork in the road between, like, say, your traditional physical therapist and a pelvic floor therapist? Is there a certain, what I would say, like, checklist where you'd be like, okay, yeah, you should go to your, more traditional PT versus coming to see someone like yourself?
There are a couple, and certainly too, if you choose one, say for example, you had low back pain and you saw your regular orthopedic physical therapist, and that person may screen you and indicate that there's also pelvic floor dysfunction. Or if you're not getting better, if you're not responding to that traditional orthopedic management, or if in addition to your low back pain, you also have constipation, urinary incontinence, a feeling of pressure in the pelvis, which would speak to pelvic organ prolapse for those with a vaginal canal. And if you have pain or issues with intimacy, those are all indications of pelvic floor muscle issues that are often found as part of the low back pain symptom. Those things can occur at the same time. But if you have isolated low back pain and none of those pelvic issues that I just described, a pretty safe bet would be to go see an orthopedic physical therapist. One of the ways that we work best together is collaboration between orthopedic and pelvic health physical therapists. And a lot of pelvic health physical therapists started as orthopedic specialists and then added the pelvic health specialty. So we can also screen. We also can treat both simultaneously. And part of being a physical therapist is having that curriculum base anyways in terms of treating orthopedics. We still know how to treat a hip and a back, and all of those are tethered and tied to the pelvis, and they are all connected.
Well, what's happening is that I had my hip replaced almost 3 weeks ago. And, my PT is very much around, like, keeping the pelvis very neutral at this point. I started PT yesterday. And I had my other hip replaced 4 years ago. So this is like, this is a part 2 sequel.
Old hat.
And, but the thing is that he's very focused on making sure that my pelvis for now remains very neutral as the hip, like the inflammation goes down, the swelling goes down, the stitches heal, and even like the IT band, a hip replacement's a very violent surgery.
Yes, it is. It's like building a house. There are hammers and nails.
Literally, you hack it out, you bang it in. And so the thing is that right now, the bulk of my pain is really more in my IT band and kind of where like my quad is hitting my knee just because of that jarring, which happened the last time. But he's very much like, in terms of giving me clearance to do certain exercises, he's very much about making sure that the pelvis remains neutral at this stage before like putting any stress on it.
That can be really hard to maintain because there's different movements. One of the primary concerns with a hip replacement is ensuring that it remains intact. It can be vulnerable to what we would call a dislocation. That sounds really scary, but we just want to make sure that all of that artwork that your surgeon does remains steadfast as it is healing. And that concern will dissipate, in the coming weeks. But yeah, it's a phase that's really hard because a lot of people don't spend time thinking about the position of their pelvis. They just pick up their groceries or get in and out of their vehicle, and you now have to be very cautious about that position. But this too shall pass, as you already know, because you are in chapter 2 of.
Yeah, I'm very lucky. I have a very supportive spouse, and he's doing all the things. It is very hard not to do certain things. Like I texted some of my friends yesterday and they're like, how you doing? And I'm like, I got cleared. I started PT. I'm ready to get out of jail.
Yes.
Like, I'm ready. So, all right. Now, a lot of Go Long's community is women 40 plus.
Yeah.
And there's a number of topics that I'm excited to talk to you about is around issues like the first time I heard about, as I said earlier, about pelvic floor issue is that a friend of mine, former colleague, who loved weightlifting, and then after her second kid, basically something happened with her pelvic floor. She explained it all to me, but it was all like a big kind of blur. But basically, she couldn't do the heavy weightlifting that she really loved doing after having her second child. So maybe we could talk a little bit about some of the more common things that you see happen to women. And now women are being told, you need to do strength training. So how does that, how do we reconcile that could be a reality?
Absolutely. And they are both a reality. The question isn't whether or not to do it, it's how and how to ease into it. There are changes that are going to happen to all of us as women as a byproduct of living to a certain age, and that is that we are going to experience perimenopause and menopause. That can be brought on earlier by medical conditions, surgeries, and different genetic conditions that can cause our hormones to enter that phase prematurely, or in the case of a hysterectomy, boom, waking up and being in menopause. And then there are certain structural issues that can occur as a byproduct of being pregnant and having delivered a baby human to the world, and that can be either via C-section or vaginal delivery. Talking first about the changes in pregnancy and delivery is that the pelvic floor can have a lot of pressure on it as a byproduct of holding up those organs in that baby during pregnancy. And then certainly different things that happen in labor, such as an episiotomy or a tear, can lead to pain and sometimes weakness of the pelvic floor muscles. And then having a C-section as well can change how we stabilize our spine and our pelvis when we go to lift. The abdominals and the pelvic floor muscles and the diaphragm, which is where we breathe from, and our back muscles form the stability canister of our spine and our pelvis. And so when we experience some of those issues of, C-section or a tear, some of that integrity can be lost. It can be regained in rehabilitation. So in pelvic health physical therapy and occupational therapy, our colleagues in OT do a fantastic job as well. We are seeking to mobilize that scar tissue so it's got good mobility and re-strengthen the muscles. Sometimes too, because of some of those birth injuries, the pelvic floor muscles, the person is guarding. And so they clench those muscles, and that can make them less flexible. It can also start to drive pain in the pelvis. And that often results in issues or pain with intimacy, constipation, those kinds of things. So we've got, too tight, we've got too weak, and we've got lack of coordination issues that can occur. If those aren't dealt with, they oftentimes get a lot worse around menopause. All of that is fixable. People that are listening, if you've had any of those issues or any of those circumstances, it's never too late. I've treated 95-year-old ladies and men who have regained continence and gone on to do the things that they want to do. So it's never too late, and it is possible to retrain them. It just takes some time. And then along those lines as well, people that have never been pregnant or had babies, going through perimenopause and menopause, when our estrogen levels start to decline around perimenopause state, we start to lose both muscle mass and bone density systematically. So that includes our biceps, where we're trying to lift our groceries. That includes our gluteals, as to how we're stooping down to the ground and picking things up. And it also includes our pelvic floor muscles. They are muscles just like everywhere else, and they do support the bowel and the bladder and the sexual organs. So that can result in a new onset of incontinence or a sense of pressure. The way that we mitigate that loss of bone mass or bone density and muscle mass is by lifting and doing gentle but impactful exercises, because for most of us, our lifestyle doesn't weave those in unless you have a very active job or you've maintained a steady physical activity that involves that. I'm a runner, so I plan to just maintain that bone density all the way through if my body will let me. But the way that we do that is often starting slow, because sometimes people reach that perimenopausal, menopausal state. They start experiencing incontinence, or they notice the decline in tone in their body, or they're suddenly having issues getting those groceries up off the ground or, out of the grocery cart. Going to where you want to be takes gentle progression, because you don't want to get injured. And so working with a pelvic health physical therapist or an orthopedic physical therapist can be really helpful to getting an exercise plan that works best for you.
Yeah, I mean, this morning I spent a half hour doing my PT exercises, because also I feel that a lot of the magic happens outside of the PT. You have to do the work like outside of your appointment in order to make it happen and kind of just like really retrain everything. So you brought up like a number of things that are interesting. So I deal with, women 40 plus who have autoimmune diseases. Is there anything that you notice with women who have autoimmune in the pelvic floor area that you're on the lookout for? If someone like comes in and they're like, I have colitis, I have rheumatoid arthritis. How do you kind of take a look at that and evaluate? And obviously this is very general, I should say, and we'll put this at the bottom, that none of this constitutes medical advice, and this is all very general, and everybody should talk to their own medical professional, and we'll add something at the end to also say that. But in general, if someone comes to you and they're like, I have, 2 or 3 autoimmune diseases, because they tend to be in clusters, how do you go about treating that?
Absolutely. We look at them as a whole person. Every person with their medical history, we spend a lot of time going through all of those conditions. And we see a lot of people with autoimmune disease in pelvic health physical therapy because of the role the pelvic floor plays in maintaining continence of bowel, and because of the role inflammation and stress and guarding response can play. We know that people with autoimmune disease, especially those with IBD, so the colitis and the Crohn's disease patient population, they are experiencing more fatigue. They are experiencing more systematic inflammation. They are trying to make sure that they understand their own nutritional needs, which can look very different for each person. And a lot of them are experiencing some combination of diarrhea and or intermittent constipation and bowel issues. A person living with really chronic diarrhea, such as those and those with celiac, which I'm in that club. They oftentimes have a guarding response to their pelvic floor, trying to make sure that they make it to the restroom in time and clenching and holding when they're having that sudden urge of to have a bowel movement. So sometimes when we're evaluating them, we are looking to see what kind of coordination behavior we see in them. So is it that they have tender points and they're too tight, or do they need additional strength? And then we're working with them also on the more lifestyle behavioral aspect, which would speak to a bit of a schedule with bowels and making sure that they have the support that they need in terms of nutritionist and a good physician team that's listening to them and providing them with really solid help, and making sure that they understand what their body is looking like. And sometimes the best way to do that is to keep a journal throughout the day of, I ate this, I drank this, and here was my bladder schedule. Here's the times I urinated, and here's the times I had a bowel movement, and helping them to make sense of it. So we don't just treat and speak to the pelvic floor. We're really looking at the whole patient population, and IBD and other autoimmune disease processes can really benefit from seeing a pelvic health physical therapist.
Yeah, that makes a lot of sense. The other thing that, unfortunately is, you have people who have, say, like cervical cancer. I talked to someone recently, reconnected with them, what uterine cancer. And, so after you go through treatment like that, whether it's surgery, whether it's chemo, all of those things, do you find that you're getting also patients who have had surgery, whether it's an abdominal surgery, of some kind? Like, do you get clients like that, patients like that?
Yes, and there are pelvic health therapists that specifically treat oncological patients.
Oh, okay.
But one of the things that that patient population experiences is what I feel like is a major like pulling of the rug out from underneath them, is that when you have that cancer diagnosis, and this includes breast cancer as well, they are given the treatment plan with their oncologist, and all of the focus is on management of that specific cancer. They are not warned of the effects of radiation, specifically like on the pelvis radiation, on the vaginal tissue and on the anal tissue, if they have anal cancer or colorectal cancer. That can change the nature of that tissue. It makes it stiff. There can be scarring, and the use of dilators, both vaginal and anal, is imperative to ensuring that they are able to have their medical exam after that. They have to have ongoing screening, and getting a speculum inside of the vaginal canal after radiation can be really challenging. I've had patients describe it as torture. And that's where using the dilators ahead of time, and not just that speculum, but also being intimate afterwards as well. You worked through and you're a survivor now. You want to live a fullest quality of life, and that includes intimacy, which can be challenging there. And then on the bowel side of it, also being able to have a bowel movement. So that has been a lot of my focus in the last few years, is working with cancer survivor providers and specifically radiation oncologists to get them introducing dilators. And I will give the caveat of I created both vaginal and anal dilators, but I'm passionate about it because of the results, to getting them to introduce them sooner so that we can preserve that vaginal tissue. And then as pelvic health physical therapists, we are there for you, whether you're in treatment or on the other end when you're feeling ready and you're coming up for air and you're ready to have more appointments, because it can be a lot.
Yeah, and I want to definitely get into the dilators and everything else, and for people to understand what they are and what they are not, because I think that that's important as well. But it does lead into, like sexual health. And I'm a big believer that sexual health is as important as any part of your health, right? It's not like a secondary thing. We are all sexual beings, and it's important to be able to experience whatever it is that you want to experience. And I think that people kind of downplay that. They might go to a pelvic floor specialist because of, say, like your initial injury type of thing, or something happened after pregnancy and, they just are not functioning, like being able to live their life, or they're dealing with an incontinence issue. But I do want to talk about the sexual health aspect of this. Do people just come to you straight? Do you get referrals from, say, like couples therapists, sexual therapists? Like, how do people generally like get to you to work on issues related to their sexual health?
All of the above. So certainly I've had people that have done their homework and they've been Googling and they've sought the solution independently, and they come in and they say, I know what you do. I need help. Here's why. Let's go. And then have people come in from all different types of counseling, sex therapy, and then all the different types of physicians, urogyn, gyn, gastroenterology, primary care, all of those. And then on the opposite end of the spectrum, I have people that come in who maybe were referred by a gynecologist and told they need pelvic physical therapy, and they've they've seen an orthopedic physical therapist, and they wonder, what is she gonna make me do push-ups? What on earth is she gonna do for my gynecological and sexual health? So really and truly, I've seen it all in terms of those, how a person enters. And certainly when a patient comes in by a well-educated provider or someone who's done their own homework and they understand what's about to happen, they come in more comfortable and ready than the people that, just received the script and had no clue what they were in for, but they showed up. I mean, I have to hand it to those people. They show up. And they let me educate them on what we're here to do together.
Well, that's really good because, for a while, let's take physical therapy, which I've done plenty of as someone who wasn't active and then all of a sudden decided to make physical activity as part of my life like 20 plus years ago. But I've had two really great physical therapists, my current one being one of them, and then the other one moved away. But I've had some pretty shitty physical therapists. And I'm guessing in the pelvic therapy space, it's not immune to people who are really good at their craft versus people who, maybe aren't as, I guess, not as attentive, right? So how would you advise someone, because, you're in Oregon, there's people all over who are listening to this. How would people be able to assess, someone who is a good fit for them?
Absolutely. If you're getting a referral from your provider, that's usually a good sign that provider at least has knowledge of that pelvic physical therapist. It doesn't always mean it's going to be a good personality fit. As there are every different type of human being on the planet, there are every different type of pelvic health physical therapist. I will say, by and large, those of us that have chosen to come to this field are pretty empathetic and pretty good listeners, but that is not always the case. And I know that I have colleagues out there that need to do better. And so if you find yourself in a room with a pelvic physical therapist and you are really knowing that this is not a good personality fit. Maybe it's not a good personality fit, or maybe you've identified they're not as well trained as they should be. They don't have answers for you. There's some instances where maybe we don't know in that moment, but we can say, I'm going to find out. I will have an answer for you next time. That is acceptable, but just not knowing, or you show up time and time again and you're only having the same treatments, you're not progressing, that's not a good fit. So I'd say it's both. It's the personality and it's the skill and training. Another way to look them up is on the American Physical Therapy Association Academy of Pelvic Health website. You can look up providers there and get a little bit more information. Usually they list what they treat, and that might give you a better sense of if they're the right fit for you.
And we'll link to that in the show notes. I'll get that link from Amanda and we'll put that in the show notes.
Yes. And then the other thing you can do is you can email my team here at Intimate Rose, support@intimaterose.com, and we can help match you by zip code as to providers that we have in our provider network as well.
Do people have to go in person for pelvic floor therapy? Is that an in-person thing, or is that something that can be done remotely?
Both now. Yeah, the new world of telehealth has really opened up the ability to provide services. I will say, having one-on-one care and having that one-on-one assessment is really helpful and can be a really impactful way of getting treatment. But if you find yourself in a location where they are not close by, telehealth is doing a world of good too. And there are some really skilled providers that are providing really good feedback and queuing and whatnot via telehealth. So it's at least a way to get some answers.
And is pelvic health covered under insurance? Is that something, like going to regular, more traditional PT, we'll call it?
Yes, we are. We are covered under all the major insurances, Medicare, Medicaid, Blue Cross Blue Shield, MODA, you name it. Different plans because physical therapy is more, it's a serial treatment. We don't see you once and wish you good luck. We tend to see you for a couple of months, and especially in pelvic health, and depending on the chronicity of your condition, a pelvic pain patient who's had years and years of pelvic pain, I might see them for a few months to a year. That's not weekly for a year. It's just that treatment we may go once a month for the last little bit of it, making sure you're okay. Some treatments are much, much quicker. So along those lines, just, being knowledgeable of what your plan includes because it is multiple visits. Many pelvic health physical therapists have gone into cash pay practices as well as a byproduct of having frustrations of the insurance model and just wanting to break away. So you're going to see both. And that's an important question to ask when you call is, here's my insurance. Do you accept insurance or are you cash pay?
If you're cash pay, do you know if you can use your HSA funds for that?
I believe so. I believe you can. Most clinics will issue a super bill, and you can submit on your own for that treatment.
Okay, got it. All right, that's super helpful. All right, so, and just to clarify for everybody, someone who, you have your doctor in physical therapy,
Yeah.
and any pelvic floor therapist is going to have a doctorate in physical therapy as well. Like it's the same type, as you said earlier, it's the same type of training. Like if you needed to go in and treat hip replacements, you can do it.
Yes.
But
Yep.
I just want people to understand that there is a level of rigor and education that goes into being a pelvic floor therapist. I think that's important to state.
Yes, and that is where, to your point, looking for the additional initials. So with a pelvic health physical therapist, you're going to see DPT. Some of our older colleagues have a master's in physical therapy and are still like very, very credentialed. It was just the change happened in the early 2000s to become a doctoring profession, and they are still fantastic. The two sets of initials that you can look for at the end of a very well-trained pelvic provider's name are PRPC, which is what you'll find at the end of my name, and then WCS, which is a women's clinical specialist. So those two different credentialings indicate that we have taken a board exam in pelvic health physical therapy. So you could see both, or you could see one or the other. I have the PRPC credentialing. But both of those are strong indicators that that person has done all of the coursework and has taken a very long test and has to recertify every 10 years. I just did my 10-year recert in May.
Oh, all right, cool.
Yeah.
Awesome. All right, so let's talk about the dilators. Now,
Yeah.
dilators, when I first saw them, they look a lot like sex toys, and there's nothing wrong with sex toys. We're big fans, but obviously sex toys have a purpose, and they have a good purpose. But the dilators might look like them, but they have a different purpose. So why don't you maybe talk about like the basics, like dilator 101, and how you use them and why they matter and how they can help you accelerate the therapeutic process?
Absolutely. So dilators are a tool. I always, my mantra is tools, not toys, but there's nothing, as you said, nothing wrong with toys. Certainly my tools could be used as toys, but
Right.
they are a tool. They are FDA cleared, which is the highest and most rigorous form of testing any product. Sex toys are not held to that standard. Our tools are, which makes them the safest choice for a patient and anyone who has had cancer or any sort of pain. What dilators are is they are a set of tools. They start, they're a cylinder shape. They start as small as my pinky, and gradually going through 8 different sizes, they get a little bit longer and a little bit wider. So we're picturing cylinders that start very small and gradually get longer and wider. They are indicated for people who have pain with penetration, and that could include using a tampon or a medical exam with a speculum or penetrative intercourse. So the dilators are a tool to gently and progressively improve the flexibility and elasticity of the vaginal canal and the vaginal opening. So we're looking to help either restore or create for the first time better length and width of that vaginal opening. It's really pertinent for patients who have had a history of trauma or abuse and they have clenching patterns to where nothing can get in, or people who have had radiation and now they have scar tissue, or moms that experienced episiotomy or tear during delivery. And then, especially in the 40 and beyond, those who are experiencing low estrogen states and they're a little drier and a little stiffer and a little less flexible. So, the dilators are used for 10 to 30 minutes a day you gently place it inside. You can do some gentle mobilization. I don't use the word stretch because oftentimes when we think about stretching our hamstrings, we think about leaning into the burn and it hurts, and that can be something that nobody wants near their vaginal opening. So we're mobilizing, and we in fact don't want it to be painful, a little uncomfortable, just as any new movement would be. But slowly but surely, as you improve that flexibility, you progress to the larger size, and that would be in speaking about sexual health. That would be in service of pain-free penetration and intimacy with your partner.
So when you're prescribing, is there like a prescription, or is it like, how does it work? I mean, or do you just say like, hey, you need size 3? Like
Yes.
how does that kind of work? And what if someone is also thinking, maybe they're self-diagnosing, they can't invest in a pelvic floor therapist, and they might want to buy one of these dilators. How would you advise them to kind of think about that process?
Sure. Our dilators are over the counter, so they can be purchased directly off of our website. You don't need a prescription. It's helpful to be using them in conjunction with pelvic therapy, but we have hundreds of thousands of people who independently treat because of a wide variety of different reasons. They don't want to go, or they can't go, or it's not part of their schedule right now. In terms of where you start, or where I as a provider would start someone, generally speaking, they're going to need more than one dilator. So when you're thinking about it, you're thinking about range of where you are now, what you're able to tolerate, and where you want to be goal-wise. And that might be the difference of 2 dilators, and it might be the difference of 7 dilators. So what we generally say is, if you can place a pinky inside your vaginal canal, generally, but it's challenging. You can start with our small set of the first 4. If you cannot, you're still starting with that small set of the first 4, but you're going to be doing a little bit of different positions and working into it. Most people, when they go from one dilator to the next, really need to start really slowly, and they're not inserting the whole length of the dilator. So for that reason, you're thinking about, for example, sexual health. If you have a partner existing, you would want to be moving up to a dilator size that was roughly the size of your partner. If you don't currently have a partner, but that's a goal,
Or you're in a same-sex relationship,
or in a same-sex relationship, then you're thinking about what's the goal. Is it speculum and whatnot? And that would be roughly size 5 and 6 or below, so that you have good mobility of the vaginal canal. You can tolerate that speculum or utilize a tampon, and that's where you're needing to go. So it's Very unique to the person in front of you and very unique to where you're starting.
I listen to Sex with Emily, the Sex with Emily podcast, and she talks about Kegels all the time. So is it also about doing Kegels? Is Kegels overrated? Like, you hear Kegels all the time.
Yeah, poor Kegels. They're so misunderstood. I feel like I've been the new PR person for Kegels or Kegels.
Kegels, Kegels, I don't
Yes.
even know the right pronunciation.
Yes. So a Kegel is a pelvic floor muscle contraction. That is what a Kegel is. So it's a tightening of the pelvic floor and a relaxation. So when you're thinking about that, usually the intention is to build strength. And there is a whole body of evidence in support of using that particular exercise to address issues like urinary incontinence or pelvic organ prolapse. So that's to say, there's a time and a place and a diagnosis for Kegels. Because there's a time and a place and a diagnosis, that doesn't necessarily mean everyone's appropriate for them. And in people that have pain or pelvic floor muscles that are too tight, it's actually what we call contraindicated or not appropriate for them because it can actually make things worse. So, if you're thinking about, am I a good candidate for doing Kegels? Generally, if you don't have pain, if you've never had constipation or pain with intercourse or any issues having a vaginal exam, and you want to start incorporating into your programming, you can do that, and it will probably be helpful to you. Those muscles back up to the gluteal muscles, so a lot of the new evidence and exercise thinking in the professional world is about combining the exercise with a gluteal and a hip exercise because they connect, because you're going to have more impact. So when you hear people in the clinical world maybe not so supportive of Kegels, some of them feel it's because we could be getting people better by doing larger scope exercises like bridges and squats and things like that. But when we're thinking specifically about people's control, we also want them to know where their pelvic floor muscles are and be able to volitionally or on command know how to contract and relax. And that's where practicing a Kegel comes in. So, to your point, they can certainly be helpful for sexual functioning. Having good, strong, reactive pelvic floor muscles can increase the experience of orgasm and sexual satisfaction, but they are not the best exercise for people who have pain.
Got it. And speaking of sexual satisfaction, do dilators help in that regard? I mean, again, looks a lot like a vibrator, a sex toy, that type of thing, but do they help with sexual feelings, orgasm, all of that?
Yes. So, looking at somebody who maybe has negative experiences with intercourse or pain, the dilator is a helpful tool to retrain their sensory system and their brain and their pelvic floor muscles to first tolerate and then to appreciate having something inside it. And then anything that is utilized over the clitoris can certainly be used for sexual appreciation. So roughly, I believe the statistic is currently 60%, but I feel that some researchers are saying it's higher. A percent of women need clitoral stimulation to achieve orgasm. So when we think about the role of a dilator going inside the vaginal canal, it's not going to spontaneously result in an orgasm. The clitoris does back up to that vaginal wall. So if somebody was doing a session and then they wanted to do more exploration or, certain maneuvering, they could certainly achieve that. But 60% of people are not going to get it with just use of a dilator alone.
I mean, I think it's an even higher number.
Yeah.
Around that. In terms of, women experiencing orgasm, it's definitely like I thought it was like something like 80% or something like that.
I would believe that statistic. Yes.
Yeah. So, but it was just interesting to me. Is it more, so it's really, I like what you said, tolerate and then appreciate, right? In terms of like what the dilator is there to do. It's helping you like be able to tolerate and then be able to appreciate, and then so you can relax and actually enjoy yourself.
Yes, because there's so many people that have pain to where like they would love to just live through it, to be with their partner. But that's not the end goal. The end goal isn't just that, you can tolerate it. It's that you're going to get to a place where you're enjoying yourself.
Okay, so I have so many questions, but we don't have all day. But I have one more question for you, going back to surgery, and the pelvic area. So if someone is going to be having surgery in that area, and if you want to include breast cancer, if it impacts with mastectomies or lumpectomies or whatever, what should people be thinking about as it relates to their pelvic floor? That when you come in and you educate people and they're just like, fuck, I wish my surgeon would have told me about this. What are questions that people should be asking their surgeon so that they can get more educated around how to be prepared for what happens when you get home?
I love that question so much because, and I was able to conquer this here in Southern Oregon, but I know it's an uphill battle in other locations. That general surgical group is the hardest one to get them to think about what happens to the patient after surgery. And so it often it falls on the primary care physician or the other care providers to that person to pick up the pieces. So I want to start by saying anytime there is surgery, even and especially laparoscopic surgery to the abdomen or the pelvis, there is disruption in the abdominal wall, and that affects the pelvic floor directly. The other thing is there's an inflammatory process as a byproduct of having surgery, and that inflammatory process can have an impact on the pelvic floor and its coordination. There can be inflammation that inhibits the muscle function, so people can experience a new onset of constipation or some new onset of pain because of compression. And then we have scar tissue as a byproduct of the healing. And that can result in changes to the integrity of the abdominal wall, which, as we talked about, it's a teammate with the pelvic floor. There can be changes to the pelvic floor itself as a byproduct of that scar tissue. And here's where, when we think about laparoscopic surgery, a patient sees these little dots in their abdomen and they think these are just little superficial dots. Those were tunnels. And the instrumentation of surgery, and this isn't to frighten you, it's just to let you know the instrument went in and down. And so that scar tissue is oftentimes several inches. So because of those changes, we want to see you in pelvic health physical therapy. We treat the abdomen. We're going to help mobilize and soften that scar tissue, and we're going to help retrain the motor control. I myself, and this was after the great accident of 2008. I've had two pretty major abdominal surgeries, both done laparoscopically. And on the second one, I've been in clinical practice. I'm now considered an expert in my field at this point for 14 years. And when I went to activate and try to do a pelvic floor muscle contraction and contract my abdominals so that I could roll over and go to the bathroom, nobody's home. Could not do it.
Wow.
And I am knowledgeable. I know how to do it, but the muscles were not going. And I took a video, and I'm friends with my surgeon. I picked him because I know he's good. And I showed him and I said, this is me. Look at how bad this is. This is why you need to send all of your patients. And it like, he was floored. Like, it was of my abdomen, to be clear. The video was not on my pelvic floor, but those go together. So, and it takes time, and it is retrainable. I will say, like, do not lose hope. It is retrainable, but there's no such thing as a mini surgery. All of those have changes, and those changes can be long felt. So it's important to make the request.
Yeah, I mean, right now with Ozempic, there's also been this increase in plastic surgery, in cosmetic surgery, because there's the excess fat there, particularly in the midsection area. And so I think that there's probably some underrated considerations that need to be taken into account. Not saying not to do it. If you want to do it, do it. Like, there's no judgment here on what everyone does with their body. But it's more of just be educated about, like, what happens. Like, with my hip replacement, every time I post about it on social media, someone reaches out to me and is like, I'm having a hip replacement. I don't know what to expect. And I have a whole email. I literally have an email on like, this is what's going to happen. This is the stuff you want to buy. Expect this, blah, 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 blah. Because a lot of times the surgeons aren't telling you about what you should expect. I mean, when I had my first one, I didn't know this. I go to the dentist and they look at my health form. They're like, wait, you had a hip replacement? I'm like, yeah. They're like, did you take an antibiotic? And I'm like, wait, what are you talking about? And it turns out that I have to take an antibiotic an hour before every dental appointment I have to prevent infection. Because obviously the mouth is like a huge vector for infection. And if I get a blood infection, that could totally mess with my device. Well, device is now. And so I have to be very vigilant about all types of infections. Like, whether it's like, I thought I had a UTI, but it ended up being a kidney stone. But I was like, I had to be like super proactive about going to a doctor and getting it checked out just to make sure that it wasn't an infection. I always try and just tell people like, find out how shitty your life is going to be after the surgery. Like I call it the shitty shit part of post-op. Like get the surgery if you need the surgery.
Yeah.
But know that there is going to be some really awful parts that are just going to suck. And the more you're prepared for it so that you have the support you need, the better off you are. So that's why I wanted to ask that question of you, because you deal with people with all sorts of maladies. And I'm guessing you clean up the pieces, as you say, a lot of the times where you're like sitting there and having to like, okay, they didn't tell you this, but, and the person is sitting there slack-jawed.
Yeah. Yep, you got it. Why didn't they tell me?
Yeah. Yeah. Yeah, that's terrible. All right, Amanda, where can people find you? I mean, we're going to put all your stuff in the show notes and everything, but, where can people find you? Talk a little bit about Intimate Rose in addition to obviously your practice.
Absolutely. Our website is intimaterose.com. I have a educational website that's amandaolsendpt.com. On social, we have a really great channel on Instagram that's Intimate Rose. My channel that focuses a little bit more, it's a pelvic health, more orthopedic running combination. On my personal one is A Olsen DPT. Intimate Rose is all the pelvic health topics all the time. And then I'm on Substack now writing. And
good. I'm on Substack too. Great. I can link to you.
I'm loving it. Yes. Amanda Olsen DPT PRPC. And then likewise with my name on LinkedIn and Twitter.
Awesome. All right. Well, cool. Well, Amanda, thank you so much for joining us. Really appreciated you sharing all the wisdom, and there is so much wisdom here. I can't wait to kind of listen to it and figure out what we're going to clip. Thank everyone. I'm thanking everyone. You could find the show. It'll be on Substack. It'll be on YouTube. We'll be linking to it on Instagram, on Facebook, on Blue Sky. I'm probably leaving out something. LinkedIn, and a few other places. But it is going to be everywhere. We'll hashtag it with pelvic health for people. But really appreciate everyone who listens to this. Please share this with people you know who may need pelvic health, particularly if you know the men in your life who may not think that pelvic health, pelvic floor therapists could actually be of benefit to them. I mean, that was a big like whoa for me, that men can benefit from this. And particularly they may suffer more in silence because they feel like it's not something that happens to a lot of men, or men don't talk about it. So I think that's really important to kind of get the word out there. But this is Going the Distance with Go Long. And I want to thank everyone for being here. And again, thank you, Amanda, for being here.
Thank you so much for having me. It's been a pleasure.
Thanks.